Hello, it's Mark Kris from Memorial Sloan Kettering, continuing my discussion about things that were discussed at ASCO that I think impact the care of patients with lung cancers. I think if I could pick one area where there was more discussion, more enthusiasm, and more data, it is in the area of adjuvant and neoadjuvant therapy. At the plenary session, we learned that giving osimertinib to patients with resected lung cancers following chemotherapy for 3 years, not just improved disease-free survival, but overall survival as well. It's a benchmark that many physicians were looking for to choose that therapy. In the adjuvant space, the data is more and more available that either an adjuvant checkpoint inhibitor in patients that do not have EGFR, do not have an ALK rearrangement, can improve outcomes. And also in the neoadjuvant space, where you do not have ALK or an EGFR mutation, that the combination of a checkpoint inhibitor plus chemotherapy is better than chemotherapy alone. Now, we have adjuvant and neoadjuvant approaches. How do you choose? Well, we're in another one of those data-free zones. We have to read between the trials to decide what to do. So what's changed now? Many years ago, there was a clinical trial by our Spanish colleagues that compared immediate surgery to surgery followed by adjuvant chemotherapy to neoadjuvant chemotherapy followed by surgery. And what they found was that adding a systemic therapy to surgery improved outcomes over surgery alone. And these were patients with locally advanced lung cancers adding chemotherapy, but that both the adjuvant and neoadjuvant were comparable. And I think many of us worked on that data for many, many years, and we have in our minds that the effects are comparable. And they clearly were in that trial that was published by Dr. Philippe. But something has changed now, and that is the use of checkpoint inhibitors. I think everybody was astounded when that first report came out from Patrick Ford and Jamie Chaft giving single-agent nivolumab in the neoadjuvant setting of a very dramatic response to that one drug. People kind of didn't think it was true, it was a fluke, it was a small number of patients, but indeed it is true. And what we've seen over and over again is the results with a checkpoint inhibitor neoadjuvantly are much improved over chemotherapy alone. In addition, we've seen data from melanoma that I think is very, very compelling. The paper by Patel in the New England Journal of Medicine. What was done in this melanoma trial was patients that were having a resection for melanoma got either 15 doses of adjuvant checkpoint inhibitor, or they got 3 doses neoadjuvant followed by 12 more doses neoadjuvant. So the same 15 doses were given either all after surgery or some pre and post. And what they found was an over 20% improvement in disease-free survival by giving those 3 doses before. So more and more, we are seeing that the effect of that checkpoint inhibitor is enhanced by giving it before surgery. Why that is, we can talk about another time, and I don't think we have a firm understanding of that. We know in preclinical studies that giving at neoadjuvant gives better results than giving adjuvant with a checkpoint inhibitor, but again, the facts are those. So what do we do now? I think the data in many cancers now is that neoadjuvant therapy makes a lot of sense. You've heard me talk about the various reasons for that, and it particularly does with a checkpoint inhibitor. And our old thinking that it doesn't matter adjuvant and neoadjuvant, I think needs to be put aside. And I ask everybody to carefully look at the data in both lung cancer and melanoma, and I think you'll see that the evidence points to it being better. It's clearly tolerated as well, and for some patients, it actually could be a much shorter course of therapy. The other part of this that needs to take into account is the need to, number one, continue to give chemotherapy in lung cancer cases. In those adjuvant trials, people got chemotherapy before the adjuvant therapy, and in the trial of osimertinib, people got chemotherapy. So chemotherapy still has a place here. and it needs to be given either adjuvantly or neoadjuvantly. The third thing is we need to know the molecular characteristics of the cancer. When you look at all the data from all the adjuvant and neoadjuvant trials, it is quite clear that patients that have driver, oncogenic drivers, particularly EGFR, ALK, and I'll throw in there ROS and RET, that have a very high chance of benefit from the targeted therapy. They do not benefit as much from the checkpoint inhibitor. So those patients, we have to look for ways to give them the targeted therapies in either an adjuvant or neoadjuvant setting, and that's being worked out right now. For those patients that do not have those drivers, they should be getting checkpoint inhibition as long as it's safe with chemotherapy, I would say beforehand, but you need to know if the driver is present. So at the time of diagnosis, even more important than ever, we must get sufficient tissue to know if drivers are present or not. So great opportunities to help our patients with recurrence, preventing recurrence after successful surgeries. Both adjuvant and neoadjuvant have been shown to help improve disease-free survival. And for those that feel that it's a strong motivator to use these therapies, it improves overall survival as well in all the trials that have looked at it so far. Use those therapies, look to neoadjuvant. I ask you to carefully look at the data and see why neoadjuvant makes sense, why giving checkpoint inhibitors up front makes sense. We don't have any direct data, whether the surgery and adjuvant versus the neoadjuvant approach is there, but I think the data extrapolating from the experience with checkpoint inhibitors and the data from melanoma suggests that neoadjuvant is going to be best for our patients.